Can you all hear me and see the screen? Hello? Can you all hear me?
Yes, sir.
Okay. So today we will be covering neuroanatomy. This will not a very extensive section, just a brief overview of few important things, the parts of the brain stem, the cranial nerves, and a few MCQs at the end as usual. Okay. So we start with the main parts of the brain. So as you know, the brain has three parts: the forebrain, the midbrain, and the hindbrain. The forebrain has again three main parts: the cerebral cortex, the thalamus, and the hypothalamus. The cortex is area of thoughts, problem solving, language, the hearing, speech, vision, all these things. The thalamus receives some sensory input and transmits some signals to the cortex and inhibits others. It's a kind of a filter. And the hypothalamus, uh, it is a very important part of the brain which regulates the body's homeostasis, the body's temperature, hunger, thirst, sexual drives, and also controls the functions of the pituitary gland. Then we come to the midbrain. The midbrain is again a kind of filter which evaluates the motor and the sensory signals. And the hindbrain comprises of the cerebellum, the pons, and the medulla. So cerebellum controls the motor activity, your balance and coordination. Pons is a pathway where the sensory signals go from the spine to the forebrain and comes down from the forebrain to the spine. And there are various centers to control various involuntary activity like the respiration. And a medulla, it's again a pathway for the motor and sensory signals. It regulates certain basic physiological functions, including the respiration, heart rate, and digestion. So, the cerebral cortex, as you have all seen the various photographs, diagrams, and maybe in real also, it's a highly convoluted structure consisting of various grooves and ridges known as sulci and gyri in plural, singular sulcus and gyrus. And the cortex divided by one longitudinal fissure is divided into two symmetrical cerebral hemispheres, okay, right and left hemisphere, which together forms the cerebral cortex. Each cortex has various depressions or grooves known as the sulci and the ridges or the elevations known as the gyri. And this is one of the cerebral hemispheres. This is the anterior end. This is the posterior end. So anterior, this point is known as the frontal pole. This is the occipital pole. This is the temporal pole. So frontal lobe, parietal lobe, occipital lobe, temporal lobe. Four lobes in the cerebral hemisphere divided by various sulci. So the central sulcus divides the frontal lobe and the parietal lobe. The parieto-occipital sulcus divides the parietal and the occipital lobes. The lateral fissure divides the temporal lobe from the frontal and the parietal lobes. And the preoccipital notch separates the occipital lobe from the temporal lobe. Okay. So central sulcus between the frontal and the parietal, parieto-occipital obviously between the parietal and the occipital, preoccipital between the occipital and the temporal, and the lateral fissure between the parietal, frontal, and the temporal. So, gross functions of each of these areas: frontal lobe, thinking, speaking, memory, movement, and that's about it. Then the temporal lobe mainly for hearing, very important role hearing. Parietal lobe for language and touch. Occipital lobe vision, color perception. Brain stem, we will come to this. Brain stem controls the temperature, heart rate, and breathing, and the cerebellum for balance and coordination. Okay, following so far? Yes or no?
Yes, sir.
Yeah. Now, as I said, these three important sulcus, the central sulcus between the frontal and the parietal lobes, lateral fissure between the frontal and parietal from the temporal lobes, lunate sulcus, you don't see here, it is a part in the occipital cortex, important sulcus. But this is not what is we saw the pre-occipital sulcus. That's a different thing. This is a different thing. Now, focus on the gyri, the elevations, the ridges. So this is the central sulcus. This line you can see is the central sulcus. This is the anterior part. This is the frontal area. This is the parietal. This is the temporal. This is occipital. So precentral gyrus. Sorry, this is the parietal lobe. Central sulcus is this one. The gyrus just anterior to the central sulcus is the precentral gyrus, seen in the frontal lobe. Okay. The gyrus just behind the central sulcus is known as the post-central gyrus, seen in the parietal lobe. Okay. And the superior temporal gyrus in the temporal lobe. These important names you must remember. They may ask you precentral gyrus is located in which lobe of the hemisphere. So precentral gyrus seen in the frontal lobe, post-central gyrus is seen in the parietal lobe. Okay. So precentral in the frontal lobe, this is the site of the primary motor cortex. Your movements, whatever motor activities you are doing, any movement, this is the primary motor cortex of the brain in the precentral gyrus, seen in the frontal lobe. The post-central gyrus in the parietal lobe, behind the central sulcus, this is the primary somatosensory cortex. All the sensations you receive, primarily they are processed in this part of the brain, the primary somatosensory cortex in the post-central gyrus in the parietal lobe behind the central sulcus. Okay. And the superior temporal gyrus located inferior to the lateral sulcus in the temporal lobe. Temporal lobe, as I said, it is about hearing. So reception and processing of the sound. Okay, this is a very important slide. Please focus once again. Central sulcus divides the frontal and the parietal lobes. Just in front of the central sulcus lies the precentral gyrus in the frontal lobe, site of primary motor cortex. Behind the central sulcus, post-central gyrus in the parietal lobe, site of primary somatosensory cortex. Superior temporal gyrus in the temporal lobe, inferior to the lateral sulcus, responsible for reception and processing of the sound. Clear, everyone? Right. Coming to the brain stem. So brain stem basically connects the spine to the cerebrum. Uh, So if you can see this line here, brainstem is not from here, it starts from inside the brain, okay? Within the cerebrum, these structures are located deep in cerebrum. It's not like cerebrum ends here, brainstem starts from here. Cerebrum is something like this. So between here, right from here, the brainstem starts. So start from here, continues to the spinal cord. So the brain stem consists of three structures: the midbrain, the pons, and the medulla oblongata. So here you cannot see the uh, midbrain because it is covered by cerebrum. So in this diagram, you see the cerebrum is removed. So the thalamus, the midbrain, they are very clearly seen now. Cerebellum lies behind, posterior to the brainstem, and the brainstem has three structures: the midbrain, the pons, and the medulla oblongata. Okay, so you know there are 12 pairs of cranial nerves. We need to know briefly about all of them, where they start from, which part of the brain, what are their main functions, not into very much details, and the course of a few nerves. Okay, where they are origin, what is their function, and briefly about courses of some of the nerves. So you start from the cerebrum, the front part, the cerebrum. Cerebrum gives rise to the first and second cranial nerves, olfactory and optic nerves. Okay. Then the midbrain. Midbrain gives rise to the trochlear nerve. Okay. The fourth cranial nerve. It has the longest intracranial length of all the cranial nerves. And if you see in a prosection in a cadaver, it's a very thin nerve, very thin and long nerve, longest intracranial length of all the cranial nerves, the trochlear nerve, the fourth cranial nerve arising from the midbrain. Then the midbrain pontine junction, the third nerve. So they are not very far apart, they're just around each other. So if you actually go from front to back, first nerve, second nerve, fourth nerve, and just beside the third nerve. Then the pons, you have the trigeminal nerve. Pontomedullary junction, the sixth, seventh, and eighth nerve, the abducent nerve, facial nerve, and the vestibulocochlear nerve. From the middle oblongata, you have the 9, 10, 11, and 12 nerves. So if you see this photograph, this is the pons. This part is the middle oblongata. This part. It will continue below with as a spinal cord. So the middle oblongata, the surface has pair of elevations on each side. So this is the midline. On each side, there's a pyramid, and then there's a groove, and there's the olive on either side. Okay, so olive, pyramid, one side, pyramid, olive on other side. So the glossopharyngeal, vagus, and the accessory nerves, 9, 10, 11 nerves, they arise from behind the olive. This is the olive. So from here, 9, 10, 11 nerves from here, 9, 10, 11 on this side. Okay, behind the olive. Anterior to olive, from here comes the 12th nerve, the hypoglossal nerve, like this. Okay, so 9, 10, 11, and the 12th nerve from here. Similarly, 9, 10, 11, and the 12th nerve from here starts like this. Anterior to olive. So first and second nerve from cerebrum, third nerve from midbrain pontine junction, and then from the midbrain the fourth nerve, longest nerve, then the fifth nerve from the pons, 6, 7th, 8th from the pontomedullary junction, and 9, 10, 11 from the medulla oblongata, behind the olive, posterior to olive, and 12th nerve, anterior to olive. All right. This is again a recap of what we have just seen. So, olfactory nerve, first nerve, second nerve from the cerebrum, the oculomotor from the midbrain pontine junction, uh, trochlear nerve from the pons, sixth, seventh, eighth. Then you have the 9, 10, and 11 nerves from behind the olive. and the 12th nerve in anterior to the olive. This is in the real prosection. So again, the olfactory, the first nerve, second nerve, third nerve, fourth nerve, fifth nerve. Uh, Fifth nerve has three divisions. This one, two, and three. We will see soon. Then the sixth nerve is here in front of the pons. Then you have these. See, if you can see this, this is the olive, right? This and this is the olive. So hypoglossal nerve is anterior to olive, okay? And these nerves, 9, 10, 11, they all come from behind the olive. This is the olive. On the back side arises the 9, 10, 11 nerves, and in the front is the 12th nerve. This is a summary of the various skull-base foramina through which these cranial nerves pass. I am repeating again and again. Please revise the base of skull very carefully. The foramen, what passes through each foramen and the other way around. Important structures pass through which foramen. You can be asked either way. They can either give you a foramen and ask all of the following pass through this foramen except, or which of the following passes to this foramen, or they will give you one structure and four foramina and ask you this structure passes through which of the following foramen. All right. So it can come in either way. So please read the skull base foramen very carefully and repeatedly again and again. Okay. So through the cribriform plate of ethmoid, you have the olfactory nerve, the first cranial nerve. Through optic canal, you have the second cranial nerve. Through the superior orbital fissure, you have the third, fourth, sixth nerve and the ophthalmic division of the trigeminal nerve. Through the foramen rotundum, you have the maxillary division of trigeminal nerve. Through foramen ovale, you have the mandibular division of the trigeminal nerve. So, trigeminal nerve, three divisions, ophthalmic, maxillary, mandibular, passing through three different foramina. Then you have the internal acoustic meatus for the seventh and the eighth nerves, the jugular foramen for the ninth, 10th, and 11th nerves, and the hypoglossal canal for the 12th nerve. Okay, all of you following?
सर सिर्फ फोरामेन या फिर फिशर वगैरह भी जो जो आप मतलब ऑप्टिकल कैनल सारा?
Optical canal fissure, there are all kinds of foramens only, no? Foramen means a hole.
मतलब पूरा का सारा ये याद करना पड़ेगा?
हाँ, जो मैंने बताया.
ओके सर.
नेम्ड फोरामेन इतने सारे ही है ना, एक आधा और होगा which I had shown in the last class. ठीक है. Okay, so we will start with the individual nerves one by one, very briefly. So starting with the olfactory nerve. So for the, this is for smell. It's a purely sensory nerve. First cranial nerve, purely sensory nerve. So this is the nose. This is the nostril. You inhale through this space. You can smell through this space. So all the aromas, good and bad smell, they all enter the nose from here. And these olfactory nerve roots, they are situated at the roof of your nose, okay, and not a single nerve strand but a bunch of fibers, so as to increase the surface area. So a single nerve will have small area. So if this single nerve divides into so many small branches, nerve roots, the surface area increases, so there is much more space to receive the sensory inputs. So the smell directly goes up to these receptors on the nerves. These pass through this cribriform plate of ethmoid. This part, fenestrated plate, lots of holes, and they all accumulate in this olfactory bulb. Okay, olfactory bulb then forms olfactory tract to the olfactory cerebral cortex, going to the precentral gyrus in the primary, sorry, in the postcentral gyrus in the primary somatosensory area. Okay. Now, optic nerve, pay attention here. Optic nerve, first of all, it's not a nerve per se. It's actually a part of the brain. Okay. It develops from the optic vesicle, which is the outpouching of the forebrain. So it is a part of the central nervous system and has its own meninges. Optic nerve, outpouching of the forebrain covered by meninges. First important point. Secondly, to see how, so the retina is where all the visual input is received. Whatever you see, whatever colors you see, all comes from the retina. The retina, so the nose is here, ears are here, known as the temporal side. Temporal side and the nasal side. So each retina can be divided into a temporal side and the nasal side. Nasal side, temporal side. Okay. So the light rays from this side, they come on the nasal side. From this side come on the temporal side. Okay. Similarly, like this and like this. This is very important to understand because based on this concept only, we will realize how the damage to various parts of the optic nerve and the optic tract and the optic chiasma lead to various kinds of visual field defects. All right. So the retina has two parts, nasal and temporal, receiving the inputs from the opposite side respectively. Then from both the sides ultimately forms the optic nerves. But the optic nerves carry distinct fibers from each side. Nasal fibers maintain their course, temporal fibers maintain their course. They don't get mingled up. They remain very distinct. Okay, so each optic nerve has fibers from the nasal and the temporal retina. Same on this side. Now they come and cross over at the optic chiasma. Okay, at this point, what happens? The temporal fibers of this side continues on this side. The nasal fibers on this side crosses to the other side. Similarly, the nasal of this side and the temporal of this side comes to here. So the right optic tract will have temporal fibers of the right eye. This is the right eye. This is the left eye. The right optic tract is having temporal fibers of the right eye and the nasal fiber of the left eye. Similarly, the left optic tract has fibers from the nasal side of the right eye and the temple of the left eye. Do you understand this?
So one more time.
Yeah. So this is the right eye and the left eye. This is the retina. This back side is the retina. The retina is divided into two parts in each eye, nasal side and temporal side. Each of them have their own distinct nerves, and those distinct nerves, they stay together and don't get mixed up with the other side, right? So when these nerves they exit the eye, they form the optic nerve on each side. Optic nerve, optic nerve. This optic nerve has distinct fibers from the nasal retina and the temporal retina. Same on this side, distinct fibers of the nasal side and the temporal side. Now, maintaining this distinction, they come and cross over at the optic chiasma. At this point, what happens? The ipsilateral side temporal fibers and the contralateral side nasal fibers, they go to one side. Okay, so the right optic tract will have the right side temporal fibers and the left side nasal fibers. Okay, right optic tract will have right temporal fibers, left nasal fibers. Similarly, the left optic tract will have uh, left temporal fibers and right nasal fibers. You understand now? Yes or no?
Yes, sir.
Sure. Everyone? This is important for the next thing we'll discuss. Okay. So keeping this in mind, understand this. Okay. So remember what we discussed here. The eyes, there will be some fibers on this side, some on this side, again some on this side, some on this side, and this will come here together, they will come here together and they will cross over. So these side fibers will continue to come on this side, and these will come over to this side, whereas this and this will stick to this side. Okay, I hope you remember that, you understand that. Now you see, this is what we have discussed. So if the right-sided optic nerve completely gets damaged, see this one. So obviously the entire right side vision is gone. Clear? Next you see, a part of this chiasma is getting damaged, not the entire chiasma, just this part is getting damaged. This part. Okay. So what will happen is, this fiber, this blue line, if you track, this is what is getting damaged. Only this part, not the entire blue part, because this part is also coming from here. So only this part, right side temporal retina is getting damaged. So it will not perceive light from this side. Understood? So the vision will be, this is normal. The nasal vision of the right eye will be gone because it will not perceive light from this side because the temporal retina is damaged. Understood this one? Yes or no?
Yes, sir.
Everyone? These are important things, okay? Now you see, 3, where this entire section is cut off like this. Now what happens? The temporal side fibers are saved. This goes like this goes like this. But the nasal fibers of each side are damaged. Now what happens? The eye will not perceive the light from the, so now nasal fibers are damaged. So this radiation, this light and this light will not be perceived. Okay. I will only perceive light from this side. So you see here, this side is dark. Okay. Only this side is visible.
Sir, one more time.
at the optic chiasma, the nasal fibers, they cross over. Okay, the nasal fibers cross over, which receive light from the two sides. So since these two sides are no longer seen, you see in this diagram, these two sides are darkened. I cannot see light from these two sides. But because this fiber is okay, this side is okay, this side you can see. So this part is light. Again, since this fiber is okay, light from this side can be perceived. So this side is seen. But from this side, it is no longer seen on either side. Did you understand?
Yes, sir.
You can. Uh, this one again, till 4 is enough for you. You don't need all this. So at 4, you see, if this part is cut off, so this has fibers from ipsilateral temporal retina and contralateral nasal retina. So if this part is gone and if this part is gone, so only this part is visible, this part is visible. So you see here, from this side, whatever light is coming, it is no longer perceived. This is dark. But since light can come from this side, you can see this part. Did you understand?
Yes.
You have to remember that at the retina, the things are getting ulta. Okay, that is what you must understand. If this side is damaged, if these fibers are no longer acting, so the eye will not perceive things from this side. This side will be dark. This is okay. So light rays from this side will be perceived. This will be okay. So this switchover you must understand to understand these diagrams. Okay. So if this part is damaged, again you see if I divide the eyeball into half like this. Okay. So this fiber is gone. So light from this side will not be seen. So this is same as this image. You understand now? Yes or no, guys? Please respond. Okay. So you keep drawing and practicing these. This is important. 1, 2, 3, and 4 you must remember to practice. One you cut here, one you cut here, one you cut here, and one you cut here. So 1, 2, 3, and 4. At least these 4 defects you must understand. Which part, Dr. Saroj? In the eye, the retina is divided into two parts, nasal and temporal. So if the fibers receiving light of this side is damaged, you trace this blue line. In this fourth condition, we saw the blue fibers are gone. So blue fibers means this fiber and this fiber. This part of retina will receive light from this side. this part of the eye will receive light from this side. So if these fibers are not able to receive the light, then this side of the visual field will be gone. Similarly here, if these fibers cannot receive the light, then the vision of this side is gone. Whereas since the orange tract is okay, the orange fibers are receiving light from this side and this side. So this part is still seen, resulting in a defect like this one. Did this answer your question? All right. Next, we continue with the oculomotor nerve. So, oculomotor nerve is a mixed nerve. No, mixed nerve. It has motor, parasympathetic, and sympathetic supplies. So, motor. So, oculomotor nerve supplies all the extraocular muscles except lateral rectus, superior oblique. I hope you remember the names of the muscles. We will come to them again. So, you have the superior rectus, inferior rectus, lateral rectus, medial rectus, superior oblique, inferior oblique. 6 muscles along with levator palpebrae superioris. Now, so of these, except LR and SO, all the other extraocular muscles are supplied by the oculomotor nerve. LR6 by the abducens nerve, SO4 by the trochlear nerve. So oculomotor nerve supplies all the extraocular muscles except SO4 LR6. Parasympathetic supply to the sphincter pupillae, it constricts the pupil, and sympathetic supply to the superior tarsal muscle to help raise the eyelid. Okay, so it starts from the midbrain at the oculomotor nucleus. It crosses two arteries: superior cerebellar artery, posterior cerebral artery. Okay, it passes through the cavernous sinus, through the superior orbital fissure, and supplies all these muscles, right? For the parasympathetic supply, it passes through the ciliary ganglion. So important structures in relation to the oculomotor nerve starts from the midbrain at the nucleus, crosses two arteries, superior cerebellar, posterior cerebral, passes through cavernous sinus, then through the superior orbital fissure to supply all the muscles. Parasympathetic supply to the constrictor pupillae via the ciliary ganglion, the parasympathetic ganglion. Okay, take your time, note this down. Shall I proceed? Angular sparing, do you need to know? It is a quite a little complicated thing. I also don't recall the exact concept. It has something to do with this kind of a field. There is some difference in the retinal fibers at the macula. So even if the nerve is gone, something happens in the macula. I don't recall the exact concept. If you want, I can read up and tell you. But as far as the things I have seen in your questions, I haven't come across that, so I didn't put it in my notes. If you want, I can get back to you. Anything else you want to know? Okay, so we will continue with this. Trochlear nerve, as I said, it is the longest intracranial course and it supplies the superior oblique muscle. Starts from the starts actually from behind the midbrain. Okay, passes these two same arteries, superior cerebral, posterior cerebral, passes through the supraorbital fissure and supplies the superior oblique muscle. Then the abducens nerve, the sixth cranial nerve, starts from the pontomedullary junction. It crosses close to the internal carotid artery and passes through the superior orbital fissure, supplies the lateral rectus muscle, LR6. So these are the movements of the various muscles. So right eye, superior rectus will move the eye upwards. Superior oblique will take the eye downwards. Similarly, the inferior oblique upwards, rectus downwards. So obliques will have the opposite function as the name. Superior rectus upwards, superior oblique downwards, inferior rectus downwards, inferior oblique upwards, medial rectus medially, lateral rectus laterally. Nerves, so all the muscles by the third cranial nerve except SO4, LR6. Okay, keeping this in mind, we need to understand this. We won't go into too much of details in this, just briefly we will understand. So this is the normal eye. Okay. You ask the patient to look right, he will look right with both the eyeballs, look straight, look left. No problems here. If there's a third nerve palsy, third nerve palsy means the superior oblique and the lateral rectus are okay. So right third nerve palsy. First point you see there is ptosis. Can you see there is ptosis? It is because the levator palpebrae superioris muscle is involved. Okay, it is weak. Now, so if the patient is looking towards the right side, okay, so lateral rectus is okay, so patient can look towards this side. You also see the pupil. The constrictor pupil is not functioning. This side pupil is dilated. You can compare these two pupils. This pupil is dilated and there is ptosis. Okay. These are the two distinct features of a third nerve palsy. There is ipsilateral ptosis and pupillary dilatation. Right. Now, when the patient is looking straight, again, the lateral rectus is functioning. So I will be dragged towards that side. I will not be able to come to center. Same when he's looking right to left. This eye can move towards the left. This eye cannot because this side medial rectus is not working. Understand? Fourth nerve palsy. Fourth nerve is superior oblique. Superior oblique's work is to take the eye downwards. Okay. So you can see when the person is looking straight, the eye is dragged upward because superior oblique of this side is weak. So eye is not being able to being pulled downwards. It is dragged upwards. And sixth nerve palsy, the lateral rectus of this side is not working. So eye is dragged medially this side. All right. So it is very easily understood when the person is looking straight. So when looking straight, you see this is normal. Here there is ptosis, pupillary dilatation, and the eye is laterally. In fourth nerve palsy, the eye is dragged upwards, and in sixth nerve palsy, the eye is dragged medially. This is clear to everyone? Yes. Thank you. Now, trigeminal nerve. This has the biggest nucleus of all the nerves, means the biggest site of origin of all the nerves. Okay, it extends from the midbrain, pons, and medulla. Such a big nucleus with three parts. So, nucleus is where these nerves start, a cluster of nerves. A cluster of neurons in the CNS is known as nucleus. Outside the brainstem, outside the brain, is known as a ganglion. So nucleus. So there are three named nuclei: mesencephalic nuclei in the midbrain, the principal sensory nucleus in the pons, and the spinal nucleus in the medulla. So these three nuclei make up the origin of the trigeminal nerve. They come together to form the trigeminal ganglion, which give rise to the three divisions: the ophthalmic, maxillary, and the mandibular division of the trigeminal nerve. Okay, trigeminal nerve, mixed nerve, long origin from midbrain, pons, and medulla. Three nuclei: mesencephalic, sensory, and spinal, forming the trigeminal ganglion, giving rise to three divisions, which we will see individually. So once more, motor root, sensory root, forming the ganglion, and three divisions: ophthalmic, maxillary, mandibular. Ophthalmic passes through the superior orbital fissure, maxillary through the foramen rotundum, mandibular through foramen ovale. And this is the supply. The ophthalmic nerve, ophthalmic division is sensitive to this green shaded area and parasympathetic to the lacrimal glands for tear secretion. Maxillary division sensitive to the blue area, parasympathetic to lacrimal and nasal glands. And mandibular division sensitive to the orange pink area and muscles of mastication supplied by this division and secretomotor parasympathetic to the salivary glands. Okay, so all the secretions of the head and neck region, tears, nasal secretions, salivary secretions, they are all controlled by the trigeminal nerve. You may have dry eyes, dry mouth, all in relation to the trigeminal nerve injuries. Now the facial nerve. Facial nerve, if you recall our head and neck section, Facial nerve is the nerve of the second pharyngeal arch. It has various motor supplies to the muscles of facial expression, posterior belly of digastric, the styloid and the stapedius muscles. Sensory, a small area around the external ear, and very important, taste via the chorda tympani to the anterior two-third of the tongue. Okay. So second pharyngeal arch, motor to facial expression, posterior belly of digastric, styloid stapedius, sensory to a small part in the ear, and taste via chorda tympani to anterior two-third of the tongue. This is the course of the facial nerves. Starts from two roots, motor and sensory. There is the the first nerve is first. So this is where the nerve comes out of the brain, of the skull. So the first intracranial branch, greater petrosal nerve. Then the small nerve to stapedius, and the last intracranial branch is the chorda tympani nerve. After it comes out, the first extracranial branch is the posterior auricular nerve, then gives small fibers to digastrocylindrome, and then enters the parotid gland, divides into temporofacial, cervicofacial, and gives out the 5 end branches. Okay, motor root, sensory root, first intracranial branch, beta petrosal nerve, then nerve to stapedius, and then the chorda tympani comes out, gives the posterior auricular nerve, nerve to digastric, nerve to styloid, goes inside the parotid gland, divides into 2 trunks and 5 end branches. This is the course of the facial nerve. Is this all right? Yes or no? Please respond, people, when I'm asking you something. Okay, so I assume you are speaking for everyone. Now, those end branches. So, temporal branch to frontalis, orbicularis oculi, corrugatus superciliaris. So, these are all various muscles of the facial expression. All these muscles. Orbicularis oculi, this is for around the eye. Orbicularis oris, around the mouth. Then depressor labia inferioris, depressor anglioris are for the lips and the angle of the mouth. So these are the 5 end branches which supply all the muscles of facial expression, facial nerve. Now, one important thing to understand here is, I'll come to that later. So what happens to the lesions? If so, we have till here is the intracranial part, petrosal nerve, stapedius, chorda tympani. If there are intracranial lesions somewhere around here, so muscles of facial expression will be severely weakened or paralyzed. There will be reduced taste, reduced salivation. Nerve to stapedius, it controls the movement of the stapes. Stapes helps in uh, sound impedance, means a very loud sound will be blocked by the stapes and the intensity is reduced when it goes to the inner ear. So if that function of stapes is lost because the stapedius is weak, so even the normal sound will be perceived as a very loud sound known as hyperacusis, hypersensitivity to sound, because the stapes, which normally tones down those loud sounds, is not working. So hyperacusis because of nerve to stapedius paralysis. Similarly, the GSPN, petrosal nerve, is for tear production, so dry eyes. So intracranial, so everything below will be damaged, right? Facial muscles are paralyzed, taste is gone, hyperacusis, reduced lacrimation. But if the lesion is extracranial, then depending on where the injury is, mostly, so these nerves will not cause a very significant clinical outcome, but it will definitely understand that the facial muscles are paralyzed. That's a very, very um, clear, distinct, visible feature of facial nerve paralysis. Now, here, this is something you need to understand also. So, you see, from the cerebral cortex, the nerve fibers are coming to the facial nerve nucleus. Okay. So, these fibers are called supranuclear fibers. Fibers coming out from the nucleus to the face are the infranuclear fibers. Okay. These are upper motor neurons. These are lower motor neurons. So above the nucleus, supranuclear fibers, upper motor neuron. Below the nucleus, infranuclear, lower motor neuron. Okay. Now you see how the face is innervated. The face doesn't receive directly from the brain. The fibers come from the facial nerve nucleus. So the upper part of the face, one is this side always there, right and left. But the upper part of the face, see the forehead. The forehead has fibers, both supranuclear and infranuclear. See this diagram carefully. See, this is the nucleus. This part is the supranuclear. This is the infranuclear. Forehead has fibers from both the supranuclear and the infranuclear. Okay. Whereas the lower side of the face has only infranuclear innervation. Okay. This is one thing you must remember. Upper half of the face, upper side, both supra and infranuclear innervation. Lower side, only infranuclear innervation. This is one thing. Second thing is that the nucleus itself, the infranuclear fibers come from the opposite side. If you can trace the black fibers, the infranuclear fibers come from the opposite side, whereas the supranuclear come from both the same side and the opposite side. Okay. So now let us combine these two things. Fibers are coming from the cortex. Okay. They are supranuclear fibers. So supranuclear fibers, some of them are going to the same side, some to the other side. Okay. From the point of nucleus, above the upper part of nucleus has fibers from both the same side and opposite side, and it supplies the forehead of the same side. The lower part of the nucleus has fibers from the opposite side. It supplies the forehead and the lower part of the face. So, keeping these concepts in mind, if you have a lesion here, supranuclear, upper motor neuron lesions, so you see what will happen. Trace the pink lines. So, this side, this part is gone. So, the pink line to here is gone. The black lines to here is gone. Pink line to here is gone. Okay. But you see, the upper side of the face has supply from the opposite side as well. Okay. But these black fibers, which supply the lower part of the face, come only from this side, the opposite side. So in case of a upper motor neuron lesion, only the opposite side, lower half of the face is damaged. All right. But if it is an infranuclear lesion, these fibers supply both the upper part and the lower part. So this entire half of the face is damaged. Do you understand this? Okay. This is the eighth nerve. It's a purely sensory nerve. It has two components, vestibular and cochlear. They combined from the vestibular cochlear nerve. The nerve emerges from the brain at the CP angle. It exits the cranium via the internal acoustic meatus. Within the meatus, it splits into vestibular nerve and the cochlear nerve. Okay, they start in the brain in two different nuclei. Then they combine to form the vestibulocochlear nerve. They travel in the brain just before coming out of the bone of the meatus to supply the end organs. It divides into the vestibular nerve and the cochlear nerve. The vestibular nerve is for the balance, innervates the inner ear for balance. Cochlear nerve also goes to the inner ear for hearing. So inner ear is a very important structure of our body, which is responsible for both hearing and balance and coordination. Okay. At this point, you must remember that cerebellum is also a very important organ for balance and coordination. And there are distinct ways to identify which is the damaged organ in case of problems. If the patient cannot maintain balance, if there's loss of coordination, the person cannot walk in a straight line, there's nystagmus. There are various signs and symptoms of loss of coordination. So it is clinically possible to identify whether the problem is in the inner ear or in the cerebellum. So vestibulocochlear nerve, purely sensory nerve, starts as two components, vestibular and cochlear. They join to form the vestibulocochlear nerve. They travel in the brain and then they divide into the vestibular nerve going to inner ear to supply the for the balance, and the cochlear nerve goes to the inner ear for hearing. Glossopharyngeal nerve, it's a mixed nerve. Mixed nerve means it has both sensory and motor components. If you recall, this is the nerve of the third arch. So it innervates the oropharynx, carotid body, sinus, posterior one-third of the tongue, middle cavity eustachian tube, provides taste for the posterior one-third of the tongue, parasympathetic innervation of the parotid gland, and the stylopharyngeus muscle of the pharynx. Okay, so for head and neck and neuroanatomy, two things you cannot ignore. One are the skull base foramina, the various structures, foramina, all these things I have told you, and the arches. The arches, the arteries of the arch, the nerve of the arch, the derivatives of the arch. Very, very important. Vagus nerve, again a mixed nerve. Fourth and sixth arches via the superior laryngeal nerve and the recurrent nerve. These are the two branches of the vagus nerve supplying the fourth and the sixth arch respectively. Sensory to the external acoustic meatus, larynx, pharynx, uh, taste of the root, the posterior most part of the tongue, and motor to majority of muscles of the larynx, soft palate, pharynx, soft palate, and larynx via the recurrent nerve. And in a way, it's the smooth muscles of the trachea, bronchi, GI tract, heart rhythm. So very, very important nerve, vagus nerve. In the axillary nerve, it is a motor nerve. It has two components, spinal and cranial. Spinal part we are dealing with here supplies the sternocleidomastoid and the trapezius muscles. Hypoglossal nerve, again a purely motor nerve, supplies the tongue muscles. Okay, except the palatoglossus. There's something known as the ansa cervicalis. It is a loop-like thing, okay, with various branches. So the ansa is formed by the superior root, formed by the C1 along with the hypoglossal nerve. This forms the superior root, and C2, C3 from the inferior root, and together the ansa supplies the various strap muscles. Okay, so ansa is the source of the strap muscle supply. What are the strap muscles? The sternohyoid, sternothyroid, omohyoid, these muscles. Now, basal ganglia. This is another little complicated structure. So it's a group of subcortical nuclei. Okay, as I have told you, a group of nerves in the cerebral cortex is known as a nuclei. Group of nerves outside the cortex is known as a ganglia. So just below the cortex, there is a group of nerves known as the basal ganglia. It's at the base of the forebrain and at just above the midbrain. So it is at a very important site, okay, to have connections with the cortex, thalamus, and the brainstem. It's at the very important junction. Okay, so it connects the cerebral cortex, the brainstem, and the thalamus in between. Blood supply, MCA branches, lenticulostriate branches of the middle cerebral artery. What are the components? There is a caudate nucleus. There is the internal capsule. There's the lentiform nucleus. And there's the external capsule. Four main structures. Okay. So this you are seeing the cerebral cortex from below. Okay, we start with the caudate nucleus. So in this view, you can see these are the lateral ventricles. We will see the ventricles and the CSF flow. So these are the lateral ventricles. So at the lateral border of lateral ventricle, you have the caudate nucleus. This is the ventricle. You have the caudate nucleus over here. First structure. Then some white matter fibers separate the caudate nucleus from the putamen. This is the putamen. This green structure is the putamen. In between the caudate and the putamen lies the internal capsule, which is nothing but a group of white matter fibers. As you can see, just a white area, white matter fibers between the caudate nucleus and the putamen. Then the lentiform nucleus. This structure is known as the lentiform nucleus, which is comprised of the globus pallidus and the putamen. They together form the lentiform nucleus. Okay, this structure. Putamen and globus pallidus, they together form the lentiform nucleus. And outside the lentiform nucleus, lateral to putamen, this one, there is another group of structures known as the external capsule. Okay. So four important components of the mesoganglia: the caudate nucleus, then a band of white fibers, internal capsule, then the lentiform nucleus with the putamen and globus pallidus, then again another band of white fibers known as the external capsule. Caudate, internal, lentiform, external. Okay. Blood supply, branch of the MCA. Clear? Right. Next, we will have a look at the CSF circulation. So the CSF is formed from the choroid plexus. The lateral ventricles. Hmm? Then they pass through the, so this is a side view, this is the anterior view. So you have these lateral ventricles, then you have the, these are the interventricular foramen, these openings here, and you have the third ventricle over here. Then you have the cerebral aqueduct of Sylvius, and you have the fourth ventricle over here, which continues as the central canal of the spinal cord. Okay, so formation from the choroid plexus in the lateral ventricles, then interventricular foramen to the third ventricle, then the aqueduct to fourth ventricle, and continues in the central canal of the spinal cord. This is a MRI image, as you can see in the sagittal section. So starts from the lateral ventricle. This is lateral ventricle. This one. Then this is the foramen with the third ventricle. This is the aqueduct, this narrow band. This is the fourth ventricle, and this will go below as the spinal cord. Meninges. So there are three layers of meninges: outside inwards, dura, arachnoid, and pia mater. Dura is attached to the inner surface of the skull bone. Pia is densely adherent to the brain matter. The arachnoid is somewhere in between. Okay. So CSF is present in the subarachnoid space between the arachnoid and the pia mater. Okay. And the dura has some extensions which divide the various parts of the brain. So if you can understand this image, so Fox cerebri, this is a dural extension between the right and the left cerebral hemispheres. There was a longitudinal fissure between the two hemispheres. So in that gap, there is this dural layer separating the two hemispheres known as the Fox cerebri. In the same way, if you can see underneath this tentorium cerebelli, there is another extension below. Like if you can see this faint line below, just like Fox cerebri between the two cerebral hemispheres, there is a Fox cerebelli between the two cerebellar hemispheres. Okay, and in between the cerebrum and the cerebellum, there is another layer known as the tentorium cerebelli. Okay, so Fox cerebri between the cerebral hemispheres, Fox cerebelli between the cerebellar hemispheres, and the tentorium cerebelli between the cerebrum and cerebellum. These are all extensions of the dura. And this is the spinal cord extending. Okay, so the spinal cord The layers, as you understand, this is the dura. The outermost layer is the dura. Pia is adherent to the tissue, and arachnoid is in between. And the blue color is that you can see that is the CSF in the subarachnoid space. Okay, CSF in the subarachnoid space. So the subarachnoid space and the dura extends till the S2 level. Okay, S2 level, but the spinal cord itself ends at L2 level. Okay, this is clear. The spinal cord is not present in the entire length of the meninges. The meninges can continue till here, whereas the spinal cord ends somewhere above it. Okay, so this part, it is only a space of the fluid. Okay, so when you are doing a lumbar puncture, you have to go below the ending of the spinal cord. That is why usual site is L3, L4. You have to go in between the vertebra, can't go through vertebra. So in between the two vertebra, you have to, this is one vertebra, seeing from the back, one vertebra, two vertebra. So you have to target this space, intervertebral space between the L3, L4. This is the usual site because you still have CSF, but the cord has ended above. L3, L4 is the preferred site of lumbar puncture. Okay, so the at L2 spinal cord ends, at S2 subarachnoid space ends. The ending of the spinal cord is known as the conus medullaris, and when the spinal cord ends, there's a bunch of nerve fibers coming out like a tail of a horse. Cauda equina. Equinus means horse. So like a horse tail, there's a bunch of nerve fibers at the end of the spinal cord known as the cauda equina, and one strand of fiber from the end of spinal cord to the end of the subarachnoid space known as the filum terminale. This one strand connects the end of spinal cord to the end of this subarachnoid space. Okay, so three layers of meninges: CSF in the subarachnoid space, spinal cord ends at L2, subarachnoid space ends at S2, cauda equina at the end of the spinal cord, filum terminale, a band connecting the spinal cord to the subarachnoid space. Was this clear to everyone? Yes. Okay. Blood supply of the brain, very important. Circle of Willis. So you start with two arteries, the internal carotid artery and the vertebral artery. The internal carotid artery gives three branches: middle cerebral, anterior cerebral, posterior communicating. Okay. The vertebral artery continues upwards. It joins to form the basilar artery, which gives various branches. You don't need to remember everyone, all of them. But the basilar artery divides into posterior cerebral artery. Okay. And these arteries now form the circle of Willis. So you have the anterior cerebral of two sides with the anterior communicating, anterior communicating. Then you have the posterior communicating, and you have the posterior cerebral. This is the circle of Willis. So I'll repeat. This is where you have the ICA, internal carotid. So anterior cerebral, joined by the anterior communicating. Posterior cerebral, posterior cerebral with posterior communicating. This forms the circle of Willis. Internal carotid, three branches: middle cerebral, anterior cerebral, posterior communicating. Vertebral artery joins from the basilar artery, which gives the posterior cerebral. So remember, anterior and middle cerebral come from the ICA, posterior cerebral from the basilar artery. And the middle cerebral artery is known as the artery of cerebral hemorrhage. Most of the strokes they happen because of some branch of the MCA. Okay. Yes. Okay. And for the sake of completion, some dural venous sinuses. So in between, I told you the fox cerebelli, tentorium. So the dura has some large venous spaces. Okay, they are known as sinuses. Okay, so there is the superior sagittal sinus running in this longitudinal fissure in the fox cerebri. Then you have the occipital sinus. You have the inferior sagittal sinus. You have the transverse sinus on each side and the straight sinus with a tiny vein of Galen. And the cavernous sinus, there is the sphenoparietal sinus, supraparietal sinus, inferior sinus, and the sigmoid sinus. So the transverse sinus and the sigmoid sinus, they combine. I'm sorry, the transverse sinus continues as the sigmoid sinus, and the sigmoid sinus, this one, with the inferior petrosal sinus, they form the internal jugular vein. Remember this. The transverse sinus on each side goes as the sigmoid sinus, this one and this one. The sigmoid sinus with this inferior petrosal sinus, this one and this one, along with the sigmoid sinus, they form the internal jugular veins. Okay, so IJV is formed by sigmoid sinus plus this inferior petrosal sinus. Okay. Okay, now we will discuss a few questions. Please participate, everyone. Today I am very unhappy with the response. Yes, guys, start. Very simple, just discussed. Others, wake up, you lazy guys. Get up. Please answer. Yeah, just discussed. Very simple. MCA. Subarachnoid space. Till which extent? Yes. Okay. So answer is C. Because remember this thing we just discussed this one. Subarachnoid space coming till the level of LS2. The spinal cord ends at L2, L3 level. The subarachnoid space is continuing till S2. Read the question very carefully, read the words. Simple thing which you know the answer, you will get it wrong. Which nerve passes through the supraorbital fissure? Yes, the answer is obviously V1, the ophthalmic branch of the trigeminal nerve. Following stimulation of the parasympathetic system, which one of the following are you likely to observe? This is T. Okay. In performing a lumbar puncture, operator needs to be familiar with the anatomy. Which of the following is relevant to this lumbar puncture procedure? In newborn baby, the spinal cord occupies the full length of the dural sac. The dural sac in adult terminates at the lower end of the sacral canal. Spinal cord in adult is usually between L1 and L2. Average length is 30 centimeters. Yeah. So this is what we discussed. Even in the newborns, the spinal cord doesn't extend till the full length. Okay, it's a little longer, not the entire length. Okay, so that's all for today's class. This is a difficult section, no doubt. Plus, but please keep revising. Read what we discussed today. Practice on MCQs, and you will definitely get, I suppose, 5, 6 questions from anatomy, which is not a very big topic as per your entire course is considered, but these are quite straightforward, and they don't go into too much of depths. Focus on what we have discussed over the last several classes. Revise those topics again and again, and all the best.